Morning, guys. All right, so let's just go ahead and jump right back into lecture so that way we can try to get through as much of this anatomy as possible. So we stopped off talking about joints after our last lecture, so let's go into a little bit more detail about those. The glenohumeral joint, if you remember, this is the actual ball and socket joint of the shoulder. It is where our humerus is meeting that glenoid fossa of the scapula. If you remember, we describe it as a golf ball and tee. Very, very shallow, lots and lots of movement, very unstable. The higher the degree of movement, the less degree of stability that you're going to have there. There is a labrum. We do see a lot of injury issues with overhead athletes and the labrum, as well as athletes like gymnastics who use the labrum as shock absorption. As far as around the head of the humerus goes, like if this were the humerus, you do have a joint capsule that kind of wraps around it to try and help hold it onto that glenoid fossa. We separate those into a superior, middle, and an inferior. We talk about the ligaments of that area. Typically, they go from the coracoid over to the humeral head. That is what we're talking about when we talk about the coracohumeral. The big thing about ligaments with this unit, and same as it has been, whatever the bony part is, that is what the ligament is named for. Now, so the glenohumeral, glenoid fossa, humeral head, that is what's divided into superior, middle, and inferior. The coracohumeral is also really important as far as the capsule is concerned and trying to hold on to that and help add stability. Just another picture. Here's a good x-ray picture showing you've got your glenoid fossa is right here. Your humeral head sitting exactly how it should. We have the acromion process here. What's nice is here in the x-ray, you can actually see that there is a gap between the acromion process and the clavicle. Obviously, we know that's filled in with ligaments. We don't see them on x-rays. And then this darker part here, is actually the coracoid that's actually projecting towards us, but because it's two-dimensional, we can't see that. Now, the sternoclavicular joint, remember that was the sternum and the clavicle, extremely, extremely strong, had that fibrocartilage disc between there. You are more likely to break the clavicle than to dislocate that, if you remember. This joint is the only direct connection between the upper extremity and the actual torso or the trunk, okay? I'm not worried about you knowing the ligaments of this area. I just want you to know how very important this joint is. And then here you can kind of see it on that same x-ray, just trying to point it out. This is where the clavicle ends and meets up with that top part of the sternum. And then the acromioclavicular, so that very topmost piece of our shoulder. It is the lateral end of the clavicle, the acromion. We call it the AC joint. You hear people talk about a separated shoulder or an AC separation. Well, those are directly referring to the acromioclavicular joint. So that's how we kind of relate it to sports. We do see it a lot in sports injuries, and we will get into that when we start talking about injuries. It's pretty weak. It's pretty easy to tear. There are some ligaments in there, acromioclavicular ligaments, and then the coracoclavicular. The coracoclavicular keep it from flopping upwards, and then acromioclavicular just spans that gap that we saw in that first x-ray. So this gap is spanned by the acromioclavicular, and then from the coracoid, there were those two that come up and help hold that clavicle down. Here has the majority of those broken down, all of those ligaments. So coracoclavicular, I'm not worried about you knowing the names, the fact that these have two different names. I don't care about that. These are the coracoclavicular. The coracoacromial, very important. This is our tunnel ligament. You need to remember it as such. It is a tunnel ligament. Then we have the coracohumeral, so coracoid to the humerus. These are those glenohumeral, so you've got the superior, middle, inferior, and then it kind of gets overrun, but your bicep tendon, it does come up through this area because that is the bicipital groove. Now, the coracoclavicular joint. Like I said, we do consider this a joint because those ligaments, it is going to help keep that clavicle in place and keep it connected to the scapula, okay? It is divided into two parts, that ligament. I don't care about you knowing that it's the trapezoid and the conoid. I do want you to know that it connects at the conoid tubercle, okay? It's the only part of the clavicle that you need to know is the conoid tubercle. That is where those ligaments attach. And yet again, here is where those ligaments are going to run. You can kind of see a little bit of that bump right here. That is what that conoid tubercle is. So that's where we're going to see those ligaments. Now, the scapulothoracic joint. This is that one that I told you that people don't tend to think of it as a joint, but it's where your scapula moves on your rib cage. So I hope that you guys did that little activity I told you where you put your hands on another person's scapula to feel just how much movement we have. But the scapula is not attached to the ribs. It's gliding over top of them. It is the back part of the ribs. It's close to the spine. It is the thoracic part, but it's very mobile. It has to move. Like, just think about pinching your shoulder blades together. You're going to be able to feel that movement. Shrugging your shoulders, you should be able to feel that movement, okay? So we need that to move. A lot of times, key right here, a lot of times when we are talking about the scapulothoracic joint, we call this the shoulder girdle, okay? Shoulder girdle. So if I asked you, is the glenohumeral joint commonly referred to as the shoulder joint or the shoulder girdle? That would be the joint. The scapulothoracic joint is the shoulder girdle. Okay, so we need to understand the differences between those terms because they are frequently used. As we get into the muscles, we are going to separate the muscles into either doing shoulder joint or shoulder girdle action. So you're going to need to make sure that you understand the difference in that terminology. Okay. Now, we've talked about burses before. We've talked about the fact that they're in every main joint area. They cover bony protrusions. They help with friction. They help kind of like airbags. They fill up with fluid to lubricate an area. Now, the big one in the shoulder, the one you're going to need to remember, is the supraspinatus. Sorry, it sits next to the supraspinatus muscle. Sorry, guys. It's the subacromial. Sub meaning below, acromium, obviously, it's the chromium process. So in this picture, you've got it right here. It's blue. It's sitting underneath the acromium. Your supraspinatus, that's why I said that. Your supraspinatus muscle is coming in that same area. And then what they cut away that's important is the coracoacromial ligament. That ligament I told you to remember makes a tunnel. All of this stuff has to squeeze underneath that ligament to get down to the arm, okay? That tunnel. It's a lot like the carpal tunnel in the wrist. And if issues happen in this space where things are swelling, it's going to pinch off the nerve and the blood flow just like it can at the hand, okay? This is what we call impingement syndrome. Just completely lost my train of thought. Sorry. It's what happens when you're stuck at home in quarantine for way too long. Impingement. It can happen when you fall asleep with your arm up above your head or you're leaned over on it. How many of y'all sleep on your belly with your arms up like this? Having your arms up like that actually pinches this area and can lead to impingement. That's why you might wake up in the middle of the night and it feels like your arm is dead. You can't feel it because that area got pinched off while you were asleep. That's a very simple, non-injury form of impingement. So imagine if you had irritated those muscles in that area bad enough that they had swollen up on their own and they were causing that pinch of that nerve all the time. It's painful. It's debilitating. It's problematic pretty much all the way around, okay? But this is the main bursa that we have to deal with, okay? So subacromial, it has to deal with the supraspinatus muscle and the coracoacromial ligament. Now, circulation is also a very big, important part. We're going to talk about the nerve part completely separate. Probably on Monday we're going to talk about that. But as far as the circulation and blood flow is concerned, we do have the subclavian artery. This one is a very important one. Obviously, anytime we're saying artery, we know that we're taking blood from the heart to the extremities, further away. The subclavian artery runs underneath your clavicle, and it supplies to the entire limb. Okay. It is distal to the sternoclavicular joint. It's moving underneath. This is one of the muscles right here. This is our pec minor. So that means this is the coracoid process. This is your first rib. They had to take the clavicle off so that you could see these things. Okay. So it's running between the clavicle, which is essentially right here, where I'm moving back and forth, in the first rib, which if you look at that skeleton in your room, there's almost no space between your clavicle and your first rib. So think about the size these are and how easy it would be to damage that area and to pinch these off, okay? There's a lot running through that area. Like I said, it's going underneath the pec minor, underneath the clavicle, on top of the first rib. I'm not worried about you knowing what it branches off into. I need you to know that that is the subclavian artery that's running right there. It's another one of the reasons why a lot of movies are fake and why I hate them. If you got shot in the shoulder, people always just laugh it off like it's no big deal in movies. If you hit this artery, you can still bleed out. It could still kill you. It's just one of those movie magic things that drives me crazy. Don't ever watch scary movies or action movies with me because I point it all out. And then here is a two-dimensional view showing the glenohumeral joint. So we are seeing just the 2D if we took a slice of it. So inside this black area is obviously inside of the joint. Okay. You've got muscle tendons, this being the supraspinatus, showing your deltoid coming up. We've got our acromion. We've got our clavicle, glenoid fossa. This is showing your labrum. So here's the bottom piece of it. Here's the top piece of it. Because it's kind of C-shaped, and this is just a 2D view, we can only see just the sliver of it. However, notice it is still ever so slightly wedge-shaped, just like our meniscus was. So that is important to keep in mind, that it is kind of wedge-shaped, just like the meniscus. Now, this is one of my favorite views. We will look at other images of this. You may have to identify some. We may use it even in our anatomy quiz. So this you need to familiarize yourself with. It looks really big and scary. I don't want you to think about it like that, okay? It's not a scary view. It's just an odd view. So we are essentially looking at a person who is, so imagine the person is standing directly in front of you and they're facing the, right-hand side of your screen, okay? That's where their face is looking. And we took their arm off. This is the glenoid fossa and their scapula, okay? That's what we're looking at. So they're looking towards the right-hand side of your screen. So there's your coracoid, which is on the anterior side of your body. Here's your acromion. Here is that magical tunnel ligament that I was talking about. Can you now see the tunnel that I was describing where all of that stuff runs? Subclavian artery, you've got your subclavian vein, you've got your brachial plexus, you've got your supraspinatus, you've got your bursa. This is a different bursa, not the one we were talking about earlier. So there's a lot that has to come on through that tunnel. That's why impingement is such a very real thing, because of everything getting squished. So here we've got your supraspinatus, which supra means above. Remember, your acromion was the end of the spine of the scapula. So supraspinatus is, supra means above, spinatus, the spine of the scapula. So that means that the next one, as we go down tendon-wise, would be the infraspinatus. Infra meaning below. Then we keep going, we have the teres minor, okay? Then on the anterior side of the body, we only have one tendon, and that's the subscap. Those four together are our rotator cuff. So this is showing how they completely and totally encompass the head of the humerus. The other things we're seeing here is that here's the superior part of the glenohumeral ligament. Here is the middle part of the glenohumeral ligament, and here is the inferior part. This is the glenoid cavity. Here is the next very, very important thing I want you to pay attention to. This is the bicep tendon. It's the long head. So bicep means 2. So we've got 2 tendons. The long head comes all the way up to the labrum. Okay, so it's kind of like the ACL and that how the ACL attached to the medial meniscus. The long head of the bicep tendon attaches to the labrum. So if you are going to have bicep tendon problems, it can lead to labral tears the same way an ACL tear could lead to a medial meniscus tear. I know that's a lot of information. I'm just trying to give you some visuals to help you make sense of that, okay? It connects all the way in. Obviously, it's cut here so we can see just that part. Please refresh yourself with this image, okay? We're going to use this image again. Here is just a really good example of what happens if we have an AC joint problem. So this one, remember how I said these corticoclavicular ligaments keep the clavicle from floating up? Here's exactly what I meant. They're floating up because these are torn. Obviously, then it tears here. Literally, I've had athletes that did this, and their clavicles just poked straight up. They don't tend to come through the skin, but they just lift up. It's so weird. You can actually touch it, and this is the way we test it. It's called the piano key sign, and we push it down, and if it pops right back up, we know that there's no fracture. They just tore the ligaments. Okay? Sometimes that can be severe enough, and I've had one athlete that had to do this. They actually had to have a surgery where they sutured it back down. They used K-wire to suture it back down to the coracoid process, and then once they did that, this will scar back down. The acromioclavicular ligaments will. We've already talked about the bursas. Here's another image. Remember, I only care about the subacromial. It's the only one I want you to know about. And then we'll go ahead and stop there, and muscles will be what we will start with on Monday. Now, I'm also going to be attaching another video that I want you to watch that has to do with an injury to the brachial plexus, which is the nerve aspect of the upper body. If you've already seen it, fine. That's fine. But you're still going to watch it because we are going to discuss what those nerves have to do. And he is just a great example of it. Okay. So if you've already seen it, that's fine. Watch it again. Okay.